Hey everybody. So I had a really interesting case today that I wanted to share with you because it really hammers home this concept that your pain is not seen on imaging. And while imaging can be beneficial to look for structures that may be potentially painful, if a proper thorough evaluation is not done, then that imaging is just a small piece of the puzzle. But unfortunately, it is relied on so heavily by the conventional system. And this lack of physical exams that are being done is really sad. And I believe it leads to a lot of unnecessary surgery. So my patient today has had chronic headaches for 2 years now. Initially, which I'm not even sure why the physician went down this route to begin with, but it's right-sided headache. So basically in this region here, patient has it daily, but it ebbs and flows in terms of intensity. And so some days it's, really mild, 1 out of 10 just there. And other days it spikes up to an 8, 9, and 10 out of 10. And the patient sometimes doesn't go to work because of it. Now, initially the physician thought that this was a sinus issue. And so they ordered a sinus CT, which showed some mucosal thickening and basically some things to suggest that, the sinuses were a little boggy and they might be inflamed and things like that. And so they thought, okay, your headaches are coming from your sinuses, which that can happen. Your headaches can come from sinus issues, whether it's a fungal infection or other things like that. And so the patient then started on an intranasal corticosteroid and allergy medication, which several months of that did absolutely nothing for the patient's headaches. And so from there, the physician then referred over to a neurologist. Now, you would think that also, perform some form of physical exam or refer to orthopedic or interventional pain for an actual physical exam assessment, but no, that was not done. It was referred over to a neurologist, which, it does make sense because a lot of, nerve stuff, we have to rule out a lot of the headache, migraine stuff, we have to rule out, the big, intracranial lesions or masses and things like that could be contributing to headaches. And so I went and saw the neurologist who did a CT of the brain, which came back and showed a small hemangioma, which is basically just an enlargement of blood vessels, a growth of blood vessels, hemangioma on the inside of the frontal bone. And so actually inside the skull cavity, the cranial vault, there was a hemangioma. And so it's benign. It's not malignant or anything like that. It is currently not pressing on any structures that is, in need of surgery at, life or death type surgery. However, the neurologist said, this is what's causing your headaches, and so you need to have it surgically removed. Well, the patient, wanted to have another opinion on what might be going on. And so that's where this patient started to work with me. And so immediately when I was talking with the patient, it became clear that if this were an intracranial hemangioma that were causing the headaches, I would expect it to be a bit more diffuse than what they were currently having, which was always unilateral pain in this region with their headaches. There were no other cognitive type symptoms. There were no dizziness, no vertigo, no blurred vision, nothing that again would suggest an intracranial cause of these headaches. The other thing that was really interesting was that when the pain spiked up to a 8, 9, 10 out of 10, high dose ketorolac, which is a really strong NSAID, and ibuprofen did basically nothing for the pain. And so if you've heard me talk before, anytime an NSAID does not touch pain, it always keys me into that there's a nervous system or a neurogenic component to this pain. And so on my physical exam, I did my, the intracranial stuff. So we looked at vision, reflexes, all that kind of stuff. And then also did a really thorough orthopedic style physical exam, which in this case really demonstrated that his headaches are most likely coming from a peripheral neuropathy. It's a polyneuropathy of different nerves in those regions, specifically the superficial cervical plexus, which there we have the transverse cervical, the great auricular, and the supraclavicular nerves that are piercing through what's called punctus nervosum, a common point here, right behind the SCM muscle. Also the zygomatic branch up here on the face, and also the greater occipital, lesser occipital, and then some of the cutaneous branches off the dorsal rami, which are going to have sensation back here just around the spine. So palpating those areas recreated his pain and his headaches, and he wasn't tender on the opposite side. And if it wasn't those nerves, we would expect equal things on both sides. So because there's a difference between the sides, and the difference is that on the side he has headaches, in the pattern that those nerves supply, those nerves are tender to palpation and they can recreate his headaches. That to me is a really strong indicator that what we're dealing with is a polyneuropathy of those different nerves. So basically neurogenic inflammation. So patient today had a headache that was about a 3 to 4 out of 10. And so he decided to proceed with a perineural injection therapy, which is basically subcutaneous injections of 5% dextrose around those nerves. That dextrose is going to calm down some of that inflammation around the nerves, and it happens pretty quickly. And so we used about 15 cc's to treat that whole area, and patient got off the table and his headache was gone. Now, that is a very typical response for perineural injection therapy, where we see a pretty immediate effect that can sometimes the pain or the headaches can come back slowly over a period of time. And so we're going to watch for that and then retreat when appropriate. However, if this were an intracranial hemangioma that was pressing on the brain that was causing headaches, it would have had no change if we treated peripheral nerves like this with 5% dextrose. And so I'm really hoping that this treatment sticks with this patient and that we can resolve his headaches, because my entire career would be fulfilled if I could help a single patient avoid neurosurgery for a cause of headaches that I do not believe to be the actual cause of his headaches, and therefore would have been an unnecessary surgery, putting this patient at a huge risk, because neurosurgery is no friggin' joke, people. And so I'm excited for this case. I'm going to try and keep you guys posted as patient returns. And please, please, please just remember that your pain is not found on imaging. See you later, everybody.